Welcome, welcome, everybody. All right. So got Ohio, some Canada, Missouri, more Canada, UK. All right. People tuning in from all over. Sweet. All right. So we're going to give us a couple more minutes. Let some more people tune in. We're hitting just right at that 1 o'clock Eastern. That's my time. All right, so everybody, as we go through, everybody's already been able to make comments as where they're tuning in from. As we go through the same, if you have questions or as I pose questions to you, feel free to comment the same exact way as you did where you're from, and then we'll get that as feedback and we'll get going. So if I don't answer right away, I got a computer in front of me, so excuse me, I'm tracking all the comments as they come through, and I'll get back to them. All right, so let's get to it. All right, so the case study you're given is being dispatched to a 26-year-old female who was having abdominal pain, nausea, and vomiting. You found her in her vehicle. She was trying to leave to go to urgent care to be seen, but just said she simply didn't feel safe or as if she could make it there. As you arrive, you see her. She's in her car. Emesis is on the ground. She has a GCS of 4, 5, and 6. Even though she has been vomiting, her airway is still considered patent. She's able to speak on her own in full sentences, and breathing is normal. Her skin is pink, cool, and clammy, and she just kind of is complaining of being nauseous, and you find her to be quite anxious. For environment, all you really see is just as you pictured here. She's in her car, nauseated, emesis on the ground, no other environmental concerns. Heart rate was 113, sinus tach. She was 96% on room air. End tidal of 35 with a BP of 104/70. She's afebrile, and also blood glucose is within normal limits. She's just really kind of complaining of that generalized abdominal discomfort. Within your rest of your secondary assessment, her lungs are clear and equal bilaterally in all lobes, good adequate volume, just generalized gross discomfort throughout the abdomen, but is primarily painful and tender in that upper right quadrant. She has no past medical history, has no known drug allergies, and her only prescription or medicine she takes is birth control. Her last oral intake about 1 hour before was bacon, eggs, and toast for breakfast. So we were posed with the questions: what is your differential diagnosis? What additional assessments would you like to perform on this patient? And ultimately, what would be your plan of care? So let's break down and get into it. All right, so some things start going through our mind with differential diagnosis. So we're taking into consideration that a female of childbearing age. So a lot of times that's where our brains want to go is, it's in the morning, nausea, vomiting, thinking about such things as pregnancy. Whoops, back up there. Okay, so we started thinking about things like pregnancy, um, but some questions we can go there about asking, when was the last menstrual cycle? Are you sexually active? All those kind of things. Well, as our questions we go through, we can, ask about those menstrual cycles, any chances of pregnancy, even being on, even on birth control, just still possibilities. So we can start ruling those things out by asking those things, but presenting with diffuse discomfort and in the upper right quadrant, there's really nothing going to be associated in that area with pregnancy complications. If we're thinking ectopic pregnancy, that's going to be lower down into the groin area. Okay, so we can kind of rule out pregnancy. Well, that's fun. Okay, so I think we're back here. All right, yes, we kind of rule out pregnancy. We've asked questions, recent menstrual cycles, upper right, you know, no issues there. Okay. Then we think about pancreatitis. Well, nausea, vomiting, tender in an upper quadrant of there. But generally, pancreas can be in a really epigastric area, and generally, a lot of times it's going to radiate right through the back. Just feels like a sword going right through there. But it's all isolated, just general abdominal discomfort. So, kind of ruling that one out too. And we think about bowel obstruction. So, how can we go through and rule out those things? Well, we can start asking questions about last bowel movement. Um, we can even listen for those clicks. So, we auscultate over the abdomen and we're listening for those clicks and gargles. And so, if you don't hear anything, completely absent sounds, then it might be something to be worried about. But asking things, so, last bowel movement, food intake, food outtake, and, you know, dehydration statuses and whatnot, we can go through there. And, well, we've kind of ruled that one out too. Nothing looted in there. And that's generally going to be generalized abdominal pain, and not mostly up into a singular quadrant. And then we think about hepatitis because, hey, that's in that upper right quadrant, and that's where the liver is. Large, solid organ can have that pinpoint pain. Well, with hepatitis, inflammation of the liver, we start asking questions about things that relate to it, of ways that somebody could contract a form of hepatitis. So, are they IV users, any type of alcoholism, any type of genetic disorders or family history? And do we see any like isolated inflammation to that liver? Because if they are having, major complications with their liver, could be inflamed up there. And we know with that too that issues with the liver can create jaundice, and inflammation up in there. But asking those questions about, um, uh, any type of alcohol issues, those things, that's the way we kind of start ruling that out. So none of the questions we had kind of rule out that way. Then we think about appendicitis. So we kind of ruled out pregnancy issues, and ectopic pregnancy is going to be in those lower quadrants ruled out. It's a higher quadrant, whereas appendicitis is going to be that right lower quadrant. And remember that appendicitis doesn't necessarily hurt when you push on that area, it's when you release. So that rebound pain, but again, it's upper right quadrant and is tender on palpation. So kind of scratching that out. So now we're left with this. So cholecystitis, okay? So this relates to inflammation of the gallbladder. So this is kind of where we're starting to tailor everything at. Gallbladder sits right up there underneath that liver, and just kind of the process we got to. All right, so gallbladder says right here, just a little pear-shaped organ that's up underneath of the liver, and it has some common ducts that connect right into the small intestine. So as we zoom in, gallbladder connects into that small intestine through the bile ducts. Okay, so what the purpose of that gallbladder is to store bile. So that bile is in, and it basically gets a signal that whenever the body is taken in food, especially fats, that gallbladder is going to basically squeeze and send that bile through the common duct into that small intestine to be helping break down fats. Okay, so now think about in this scenario, had bacon, eggs, and toast. So it's kind of a big giveaway of persons having complications with their gallbladder is in those events where they've ate something fatty and their symptoms get much worse. Okay, so the body has senses a high concentration of fat. The liver is sending out signals to dump more bile, squeeze it out, send it through the common duct into that intestine. Okay, but if we have events such as stones that get built up in there, those gallstones, it can block that duct. Okay, so if that duct has been blocked, if that duct was blocked by those stones and it's sensing those fats and is trying to send that signal, that's that gallbladder trying to squeeze and release the bile, but it can't. So that's causing that pain. Then that pain can worsen and cause the the nausea and the vomiting associated with that, and also just backup of bile into the body. They can become very, very ill with this. So some causes of this. Where did that one come from? Okay, sorry, I had an extra slide in there. So some symptoms: nausea, vomiting, most notably after eating those fatty foods, because again, that gallbladder's job is to release bile, help the body go and break down those extra fats just to further digest everything. Um, Okay, apologize. Technology has not been my friend today, so especially when you're live, it makes it even better. All right, so uh, vomiting occurring after those fatty foods, and then can also develop jaundice. So, like we talked with hepatitis, you could have that jaundice skin associated with that as well. Since the liver and the gallbladder communicate, if it's being backed up and it ends up interfering with the liver, that's where we can start to develop that jaundice. And then as time goes on, if it develops infections, that's where we can start getting that fever and chills and whatnot from overall inflammation, irritation throughout the body. So another big assessment that we're going to want to do is called uh, testing for Murphy sign. So as you can see in the illustration, you want to get a hand up into that upper right quadrant and ask the patient to take a deep breath. Because as you take a deep breath, it pulls that diaphragm down. Diaphragm will pull down and kind of creates a pathway for your hand to crease up underneath of that rib cage. So you'll hold up under the ribs, take a deep breath, and let your hand kind of slide on up in. You're not trying to forcefully jab anything in, but just creating pressure. So as they inhale, kind of opens up the liver and the gallbladder area. If it hurts worse, that is what we'll consider positive for Murphy sign. So in the short term, what we're going to be focused on is just kind of comfort measures, because there's nothing that we can do pre-hospital to solve or fix those gallstones or the cholecystitis that's causing that inflamed gallbladder. So we can make them comfortable and kind of focusing on their symptoms that they're having, such as the pain and the nausea and vomiting. So we can start looking at the routes of antiemetics, anti-nausea medications such as Zofran, Phenergan, and droperidol. So kind of some big three, depending on what your protocols are of what we could be going with. But going down that pathway, if you can give IV medications at a BLS level, or really any level, a really super easy trick for trying to treat nausea really quickly while you're trying to get these things on board. Open up a couple alcohol prep wipes, let them huff it. It's peer-reviewed research that shows that an alcohol prep wipe works just as well as like oral dissolving Zofran. Okay, so even if they're starting to vomit, you give them oral Zofran, they're going to vomit it back up. Or as you give them that alcohol prep and they start huffing it while you're getting an IV set up to get some, IV medications on board or IM injections, kind of speeds up the process and prevents them from worsening those complications. And then coming to pain. This is something we need to be kind of cautious of, though, and this is going to be a married couple together, because if they're already at the point to where their like their gag reflex has been stimulated and it's now sensitive, we know that pain medications can have a correlation to causing nausea. So if they're already at the point where they're vomiting and are nauseated, um, being very cautious of what we're doing when we're giving pain medicine too. So if you're going to give pain medicine, be given antiemetics too, anti-nausea medications to prevent any possible side effects from that anesthesia, giving some nausea complications as well. And then the long term, they're going to get a cholecystectomy. Okay, they're going to go in and they're going to remove the gallbladder. The gallbladder is a non-essential organ, meaning that you don't have to have it to live. Okay, so they can remove it, and there's nothing they can generally do with those gallstones if it's gotten to that point where it's causing all these complications. The only thing they can really do is remove it. And then what that's going to mean for the patient is just some dietary changes, especially within the first 30 to 60 days after their surgery. You got to be very careful with those fatty foods, Okay, so all this does now is the bile just gets released right from the liver, right into the intestine. It's not going in any type of reserve to get a sensor. It's just there's no cache. It's just kind of a direct feed. So it's going to be a large change to dietary lifestyles of finding out what's sensitive, what kind of triggers them, into episodes that are going to create some just general GI discomfort, such as additional nausea, vomiting, diarrhea, and those kind of things. Okay, so we're going to focus on just comfort measures, making sure we're treating their nausea, their vomiting, any pain. If we are treating pain, remember that there is that likelihood that giving them the pain medicine could worsen or create more nausea. So being prepared to treat that right away. So kind of that GI cocktail, if you will. Okay, so I see comments coming in there where people were saying, yep, gallbladder, gallbladder. That's what I thought. Gallbladder, gallbladder. Awesome. Yep. Now, upper right quadrant, our two big things up in there is liver and gallbladder. So, liver, the difference we're going to see there is kind of history that goes into it. The big things of IV drug users, alcoholism, those are your big two. Like gallbladder of that last oral intake. What did you eat? What were the events leading up to this? How are they presenting? And ultimately that Murphy sign. Okay, a liver, huge organ. You'll see the swelling in that area to where it's just kind of tender in multiple areas. But for that Murphy sign, right under the ribs, kind of pointing your fingers towards that right shoulder. And as I take a deep breath, let your hand kind of slide up under that rib. If it's worsened, it's positive Murphy sign, and they're going to go in and have that gallbladder removed. So think if they're at that point where they're in excruciating pain, they're clammy, they're vomiting, it was immediately after that, and you start getting that good field diagnosis of, yep, I think it's a gallbladder. Take them to some place that has surgical interventions because they're going to go in and do it. Doesn't have to necessarily be like a level 1 trauma center because they can go in laparoscopic, just make a couple little incisions, go in, snip it. The gallbladder is a very small organ, so it's quite easy to move. They don't have to completely open them up depending on what all is going on. Now, if it is evasive and the stones have, went through all the common ducts, then that's a little bit more of a invasive procedure. But again, that's not something we can tell pre-hospital. But good assessments, doing a good differential diagnosis to know what's going on with the patient, even though there's nothing we can do to really treat it except make them more comfortable, but recognition and detection of what they're going to need for that continuation of care. But yeah, awesome. Thanks everybody for tuning in. Everybody nailing right at the gallbladder in the comments and on social media. Sweet. Proud of you all. So thanks everybody for tuning in. Remember, Murphy sign under the ribs, positive sign worsens their symptoms. Treat your comfort and their symptoms. You guys take care. Stay safe.